much for these very kind words, and yes, be with you. I wish it could be different, but still a great pleasure to participate and being invited again. And I hope soon, maybe in real world and not in virtual world. I have today the topic, which is target and outcomes in psoriatic arthritis, and it might be, a little bit dry in theory, because we're talking about, scales and measurement tools, and that should help us improving outcomes of patients and improve or maximize the efficacy of the treatments that we're giving. So I might take this over. Let me try to advance. Talking about targets, of course, you have to start with treat to target, and this has moved from RA, of course, into PSA and many other fields. Actually, most of the major rheumatic diseases now have a treat to target concept, at least to some extent, and that goes beyond arthritis and spondyloarthritis to really lupus and gout, and as a classical example, and others. But when you think about the data supporting treat to target really in psoriatic arthritis, then this study of the DECOPA study was the study that really brought PSA evidence-based, brought treat to target evidence-based to psoriatic arthritis. And essentially it was the same design as the TICORA study in RA, and there was a target defined, which was a composite measure, which I will discuss later in the presentation, the minimal disease activity scale, and if patients reached that target, they were fine. If they didn't reach the target, they had to be switched. This was the tight control arm, the green one. And in the control arm, patients were just changed if the rheumatologist decided that they would need a change. So a treat to target approach versus a standard of care, more or less. And you can see, although the sequence of therapies was the same, that for the joint outcomes in psoriatic arthritis, as measured here by the borrowed ACR response measure, you can see significant differences alone by just following a treat to target approach as opposed to clinical care. And this was also seen for the skin when you take the same graph and instead of joint outcomes use the skin outcomes measured by the PASI score, you will see that you see the same effect of treat to target on the skin outcomes. So treat to target is evidence-based, and the algorithm is pretty much what we've seen in other diseases. It's giving you a main target of remission, and that's the ultimate goal of reaching this target, and of course then to maintain it. But it also gives you an alternative target that is low disease activity. And I think this is very trivial, I think, to see this or read about treat to target aiming for remission. I think the detail, how you define remission in clinical practice makes the thing, more complicated. So remission is just a term. We need to measure it somehow. When you read the treat to target algorithm in that edition, it was the spondyloarthritis target, treat to target, which is covering psoriatic arthritis as well. It says use measures of this clinical disease activity and acute phase reactance as needed. So something that measures clinics and systemic inflammation. So how do we do that? And in psoriatic arthritis, it's really a difficult question to answer. And we have to think about the dimensions and the domains of PSA. And I must admit, when I prepared this, I overlooked one slide, which came from a German slide deck that I had. I'm curious to see if you can spot that slide with German language. So keep your eyes open and your attention sharp. So the domains maybe is a good overlook using the looking at the grappler management algorithm that was published many years ago, which nicely, aside from the algorithm that you see here, gives you an idea of the relevant psoriatic arthritis domains, reaching from really peripheral arthritis, axial arthritis, and enthesitis, dactylitis, skin and nails. And when we think about treat to target, it is probably important to think about how do we measure really disease activity in all of these domains. Do we measure it? Can we measure it? And if yes, how? If we start maybe now moving to the dimensions and starting with peripheral arthritis, we have one scale, the dubsta scale, the disease activity score for psoriatic arthritis, which is measuring the arthritis, the psoriatic arthritis a component or domain of the psoriatic disease patients. And it reminds us of the SDI or CDI scale, in this case more CDI. You can see there is a swollen tender joint on the extended scale, and there is a patient global. In addition, you have a patient pain score. Pain is a relevant domain and important domain in psoriatic arthritis. And you have the CRP, and you can, on this scale, use validated cut points for treat to target. You can see here, cut points on that scale have been defined for remission or low disease activity as the alternative scale, as the alternative target. And you can see that there's a C-dubsta compared or in analogy to RA, the SDI and CDI. The C-dubsta has is the clinical dubsta without the CRP. So a cut point of 4 is remission, up to 13 or 14, depending on which scale is low disease activity. But you can also define response criteria, 50%, 75, 85%. And this is something in analogy to the ACR response rates, which are used in all trials, and they are, in fact, have been developed for RA and not for PSA, but the convention still is to use the ACR response criteria to some extent, and we have to be aware of that. The dubsta has shown to have a good construct and criterion validity. If you look at that dubsta states and the physical component score of the SF36, and you use different data sets, you can see that this is really consistently showing construct and criterion validity. So the dubsta is really the only continuous scale for peripheral arthritis. When we move to axial disease as the domain of psoriatic arthritis, of course we have all the domains that we are using in axial spondyloarthritis, and more prominently, of course, we use the Bastei scale, which is a combination of multiple questions to the patient about disease activity, mainly focusing on neck in different parts of the body, and stiffness, question 5 and 6. And a combination of this, you can calculate the Bastei, and the Bastei is an important tool to measure disease activity. It's a patient-reported outcome, so it does not have a physician component or a lab component, so it's purely patient-driven. But still, the Bastei is something that is used in many countries for reimbursement decisions on biologics. For example, it used to be in many countries that the BASTI of 4 is at least required to get access to biologics when you are, to define when a patient has failed end states. There's other components as well, and other tools as well, and this is, for example, the others improvement criteria. Now, these are more like the ACR improvement criteria used for clinical studies, and these are used in clinical studies or trials of AxSpA, but in theory they can be used as the measures also for the axial component of psoriatic arthritis, and you can see it includes several components related to disease activity on the spine, and you have to have an improvement in at least 3 or 4 of them of 20% or at least 1 unit, and no worsening in the remaining scale. Then you have an ASAS 20, and you can have an ASAS 40, where you have the 40% improvement or at least 2 units improvement in 3 or 4, no worsening in any of the domains: patient global pain, function, inflammation. There's also an ASAS 5 out of 6 definition that includes CRP and spinal mobility, whereas inflammation is not meant to be covered by CRP. Inflammation more relates to the subjective perception of information, as for the morning stiffness, for example. And you can use this type of definitions also to not measure change or improvement, but also to measure a good state, remission. Here you would then use a value that is not above 2 in each of the 4 domains, and then you have a state of ASAS partial remission. And another way, of course, is the type of assessment that we are using to measure disease activity in peripheral arthritis with the DAS. For example, a DAS scale is the astax, which is in analogy giving you a formula that weighs different components of disease activity and sums them up to a numerical scale. And in analogy to the DAS score in rheumatoid arthritis, the astax can give you a quantification of disease activity in axial spondyloarthritis, or to measure disease activity of axial spondyloarthritis in psoriatic arthritis. And you can use on that astax scale cut points that can define again remission, which is the traditionally called inactive disease, and higher levels of disease activity, which then again is something where you can do a treat to target on the axial component of disease activity. Now, there's 4 remaining domains, and no worries, I won't go in that much detail in all of them, but maybe to say we have more or less the classical ones are the classical arthritis in peripheral joints and in the axial skeleton, and we have on the other side the non-arthritis, which includes some of them musculoskeletal, enthesis and dactylitis, and some of them being non-musculoskeletal, and that's skin, of course, in psoriatic arthritis and nail disease. And just very briefly, this heterogeneity is clear to all of us, and if you look at simple, enthesitis scales, you find many different types of scales, and the biggest difference is the number of enthesial points that are assessed in these enthesitis tools. You can see the names here, and some of them may sound familiar to you. Some of them have really large number of entheses, and these tools may be primarily useful if you do a study in which you try to show effects of drugs on entheses, but probably not so much in clinical practice, where assessment of 66 enthesial points might not be so feasible. The Masses scale has 12 enthesial points, and there's the Spark and the Leeds index that have also a reasonable number of enthesial points that allow a quantification, a measurement that you can use really in follow-up, because it's important to understand if a patient has improved or not on enthesitis and enthesial pain. Nail, you can have also quite complex assessment. You can take the NAPSI score, and the NAPSI score is, and here you have a German word that Berechnung means calculation. So go into that in a moment, but you have the changes in nail matrix and nail bed, and you assess 4 quadrants per nail, and it's shown here on the right hand side, and in each quadrant you have an assessment of the matrix and the bed, and you can assess for each of them on a 0 to 4 scale for each nail whether changes are present or not present, and if you have it not present in any of the quadrants, you have 0, and if you have changes in of the matrix in all 4 quadrants, you have a 4, and if you have changes in matrix and the bed in all 4 quadrants, you have 8. So the maximal score is really 10 nails times 4 quadrants times 2 features, matrix and bed, which is 80. So of course this is not so easy to do in clinical practice, although many of the colleagues do it. There is alternatives that are simplified, and they can be simplified really down to a global scale on pain involvement, and that might be also something that is, if it's done consistently, evaluated consistently between different assessors, can be used for longitudinal follow-up. It is important also to mention that nails do not respond promptly to treatments, because nails need to grow. The nail changes need to grow out, and you need at least a couple of months to really see effects on treatments on psoriatic nails. Now, skin has different facets, and here's really the slides that I forgot to use the right one. I have the German one, so it's a German lesson now as well for the PASI, which luckily all of you know, but you can read it now in German. I was watching the previous presentation a little bit, and I know how difficult it is if you don't understand a single word. But so the PASI's, apologies for that, but I had already submitted the deck and I noted it too late. You measure the scaling, the redness, the thickness, and the scaling of plaques in 4 different regions of the body, which is the head, the arms, the trunk, and the legs. And then you do a quantification of the lesions on a scale from 0 to 6, depending on how much what the percentage of the respective region involved. And then you do a qualitative assessment of the severity of the changes of the redness, the scaling, and the induration on 0 to 4. And then you sum it up. Endsumme means you get your final score by using really the severity scale, the 0 to 4 scale for each region. You multiply it with the extension of how much it affects in that region with 0 to 6, and you weight it for the size of the region. So you get 0.1 for the head, 0.2 for the arms, 0.3 for the trunk, and 0.4 for the legs. So this is something that if you do it often, you get a very quick access to it becomes quite feasible, although it may not sound like that right now. If you look at the PASI, everyone who does PASI frequently knows that it is a tool that can be feasibly included in clinical practice. And dermatologists, of course, use it often, more often than rheumatologists, but also many rheumatologists can use it to assess the severity of skin involvement in their psoriatic arthritis patients. Now, I left out the dactylitis. There's numerical scores that simply count the number of dactylitis fingers or toes. Coming back to the treat to target now, after showing you all of these scales, one may ask, well, now we said treat to target is important. Now we said remission is important and or low disease activity. Now we have learned that there are so many domains and there is so many tools for each domain, and there might be a remission tool for each domain. But how do we do it in a single patient to understand if a patient with psoriatic arthritis is on target or not? Really, this brings us to the discussion of the dimensionality of scores. And what I've shown you so far was a unidimensional approach, really listing you tools for each of the separate domains. And you can, of course, do that and create, a puzzle more or less of different domains and see, which domains are on target and which of the domains are not. And you look at them separately. And there is also a different way to do that, and that's the multidimensional approach. That means you're looking essentially at the same domains, of course, but you are combining them into a single scale. So you're taking everything together and create one number out of all of them. And there is advantages and disadvantages of both approaches. If you think about the unidimensional approach, of course, the disadvantage is that you have multiple potential targets, and you might find yourself, in a patient that one domain is on target, which can be, for example, peripheral arthritis and skin, and another domain is not on target, say the axial spondyloarthritis component of psoriatic arthritis. This sounds like a con, but in fact, you need with unidimensional approach, you exactly know which component is a problem. And I'll talk about this in a second, why this is so important to know which domain is the problem. You do not know which domain is the problem if you do a multidimensional approach where you lump everything together and you find, your total score is not on target. You know the patient is not on target, but you don't necessarily know what the problem is. Is it the skin? Is it enthesitis? Is it axial disease or peripheral arthritis or the nails? The benefit is you have one target only. And if this patient reaches the target, everything must be fine, because otherwise the patient wouldn't reach the target. So it's more a problem if you are not reaching the target. And I'm just showing you as an example these tools, and the minimal disease activity scale that I mentioned with the COPA study is a 5 out of 7 approach to a good state for various musculoskeletal and non-musculoskeletal measures. And you can see it includes the joints, it includes the skin with the tools that we've mentioned before, it includes enthesis, a number of entheses, and even includes function. Now, there is similar to the DAS and the astax that we discussed for axial spondyloarthritis and the spondyloarthritis component, there is a PASTAS, a psoriatic arthritis DAS, more or less, that is also constructed in the way that we know it from the other DAS-based scores. And it's again using transformation for different variables and combining them to a full scale. And it includes enthesitis, it includes dactylitis, it includes function and joints, of course. And there is another approach. We had the 5 out of 7, we had the DAS-like, and we have another approach where you simply look at 5 domains, and you can categorize each domain in essentially not involved, mild, or moderately involved. And then you get a scale that you add up for each, and then you get a total score or total scale that gives you a total number that gives you the overall disease activity um, of the disease. Now, the problem is coming back to this grappler management algorithm of these multidimensional scales that I just showed you, is that really, when you look at the old grappler guidelines here, you can see the treatment strategy for not being on target is different for each of the domains. So, of course, we know that axial disease has a different algorithm without methotrexate, for example, that skin has different treatment algorithm or treatment escalation strategies as compared to dactylitis. So it is difficult to understand what to do if you're not on target with a multidimensional score. I think that's my main point here. And it makes sense because if you look at the genetic associations of different disease manifestations, there are also different genetic associations. So they are also genetically different. So necessarily, maybe this may support the more univariate approach than lumping all of them together. I'll go over the dubsta because I think I spoke a lot already. I'll go over the dubsta validation a little bit, which shows that essentially in 2 different studies that others have performed, that dubsta also corresponds well to patient-reported outcomes. But you can use dubsta, for example, on really looking from the rheumatologist perspective, where we're really treating psoriatic arthritis, probably more than psoriatic disease, which if there's considerable skin involvement, we usually work together with the dermatologist. If we don't do the PASI, it's fine because mostly patients with a severe PASI are usually also in dermatologic care because rheumatologists are usually not so, fond of prescribing ointments for the skin and things like that. And that's a fact. So mostly we're dealing with patients who have psoriatic arthritis and their skin is either well controlled or they are in a collaborative workup with a dermatologist. So the dubsta really is the tool that focuses on the arthritis component, and we have also analyzed this, if that you can use the 3 months or 6 months dubsta. 3 months is the red line, and the green one is the 6 months dubsta, to predict how well a patient is performing. So if the 3 months improvement is greater, your chance of being in a 1 year remission or low disease activity increases, not surprisingly, but you can quantify it. So it vice versa tells you if your 3 or 6 months improvement is just little, like a 25% improvement, it means that you should think about changing treatment for arthritis sooner than later, because your likelihood of getting this patient in remission or low disease activity after 1 year is also is quite low. Now, let me sum up. I mentioned that PSA is a multifaceted disease with many, disease activity targets in different domains. Complex issue, but lots of tools, no lack of tools. That's very important to say. We don't need more tools. We probably need to better know which tools we need to use. And treat to target is the basic management principle. And it's challenged by the complexity of these multiple disease activity domains and tools. I was talking about the unidimensional approach after showing you all the unidimensional tools to measure disease activity. So a unidimensional approach measures the domain separately, and you can evaluate what's important. And you can also think about, measuring the anthesial points only in patients who have anthesial pain and not requiring all scales to be measured in order to get the disease activity measured. It's quite important in clinical practice, where one of the major complaints of rheumatologists is that there's a lack of time. The multidimensional approach is nice if you reach the target because you know everything is fine. But very often, and often enough, it's the case that the patients do not reach the target, and then you're in trouble because you don't know which domain is responsible. But knowing which domain is responsible is necessary to make a treatment decision that's actually improving that problem. So psoriatic arthritis, and I've made these bold letters here to say we have psoriatic disease with all these potential affections. But mostly, if you want to look at psoriatic arthritis, then you can use a dubsta score, which is a continuous score. And at the dubsta score on target, which with, I showed you in the beginning, has a patient global and the pain component included. If the dubsta is on target, and this has been nicely shown, also there is very little likelihood of having active enthesitis or dactylitis, because this is creating pain and reducing patient global and would not allow the dubsta, even although you're just assessing the joints, even would not allow the dubsta to be on target. So with this, I'm at the end of my presentation about targets and outcomes, and I thank you very much for your attention.
Thank you very much, Professor Aletaha, for your presentation. As I said before, it was a privilege. We do have some questions for you. I will start. So, in PSA, we have only one strategy study. Is this enough? Taking into account the data that we have, are we able to say that by reaching these targets, we are really stopping the disease progression at the pathological level?
Mm-hmm. I think you're right. I mean, this is coming back to the domains issue and the fact that we have some domains that can be, affected, and if you treat them, they are healed. So the skin doesn't scar. It's not the same problem or concept that we are having with the skeleton, with the arthritis, where we are worried about damage. So I think it's important to have at least one strategy study, and I'm not sure how many others there will be. It's important to show that I think the basic principle, you're following one target, and now forget about which target it should be and which scale it should be. Following a specific numerical target is always better than just treating by your own gut feeling. And I think that's the message that has also been nicely shown for PSA and other diseases. And that's what's important, I think.
Okay, thank you very much. I think that my co-chair, Dr. Magda Pârvu, has also a question for you.
Yes, thank you, Professor, for your presentation. I know that you and Professor Smollen are the parents of dubsta score. And also, I want you to know that in our country, in psoriatic arthritis register, we use dubsta score for remission, with cuts off and so on. So we love dubsta. But what I want to ask you is if you ever, in your clinical practice, use minimal disease activity or very low disease activity as target, and if yes, in which patients? Thank you very much.
Thank you very much for these kind words, and I'm glad to hear that. And I think it's the way we developed the dubsta was also for registries to support, a collection of data. And so I'm glad to hear that. So we look at all the domains, and I think that's the most important point to make. If we are, claiming the dubsta as the primary tool, it doesn't mean that you're not looking at the other components of disease activity, the other domains. We had the same story when the C dye was developed out of the S dye. People were saying, well, CRP is important. How can you ignore CRP? It was never about ignoring CRP. It was about not making it a requirement to have in order to calculate the score. And I think that's where it comes to. That's the same thing for the multidimensional scales. You are required to measure all domains in order to get an NDA, because if you miss one, you cannot do the 5 out of 7 if you only measure 6. And I think that's the reason why we are not using it in clinical practice, and that's mainly for feasibility. But the other reason is that, of course, in clinical practice, you need also a sense of continuity. And it's nice to have a scale with cut points, but knowing where on the scale you're about. Well, you know, only for the MDA, you only know you have reached the 5 out of 7 or you have not reached the 5 out of 7. And I think that's why we are not using it in our clinical practice, but others do. To be fair, you have to say.
So thank you very much, Professor. As always, it was a pleasure hearing you and seeing you this way. And I hope everybody enjoys your talk, and maybe, I hope next year we'll see face to face. Thank you very much, Professor.
Thank you so
Bye-bye.
much for having me.
Bye-bye.
Bye-bye. Bye-bye.